clarification, I actually graduated in 2019. So 2000, no worries. But yeah, I am a physical therapist at Methodist Maine. I do not so much in a clinic per se, but I work in the acute side. So I see patients who are acutely admitted to the hospital after stroke, acute like vestibular neuritis, Meniere's, those kind of things. And neuro is my bread and butter. I'll be sitting for the neurologic clinical specialist exam in March, so very excited about that. But today I wanted to come and just kind of try and see if I could bridge the gap a little bit between the acute care PT side, sports medicine, athletic training, and some of the red flags that we teach our students at UIW to look for when it comes to seeing a patient post-concussion. So without further ado, there you go. So just going to warn you, my presentation is what I would like to call affectionately austere. No, that's just, I think that comes with part of being in a PBL curriculum at UIW, so not too wordy, nothing super crazy. But I want to address a couple of misconceptions when it comes to looking at patients referred to you with vestibular dysfunction. And this is something that I get to work with almost every day at Methodist Maine. So I ask the question, what isn't vestibular? We're going to talk a little bit about more what is vestibular in a sec. But when a patient comes to you reporting lightheadedness or the famous head rush, getting up, moving from supine to sitting, sitting to standing, that automatically triggers, rings the bell in my head saying, let's look at other avenues, other causes of this symptomology. So dizziness is a very nebulous word. People say, I'm dizzy. Well, what does dizziness mean? What does dizziness mean to you? And there's so many different things you can define dizziness as. And dizziness, I have to tell people a lot in the acute care setting, does not equal vertigo necessarily. Vertigo being that classic, not so fun, room spinning sensation. Whereas a lot of times in the clinical setting, in the acute care setting especially, I tend to hear dizziness referring to those two words above. So one of the big things that I have made it a habit to do in the hospital, and I've made it a habit to tell my students to do, is to screen for orthostatic hypotension. That's something that unfortunately gets overlooked a lot. It gets overlooked very commonly. But if your patient says, or if your client says that they're feeling dizzy, and you got to ask them, what? Like, how would you describe that dizziness? What does that mean? So cardiac screening, I'm sure you're all well aware when it comes to sports medicine that cardiac screening, all of those kind of fitness screens are, just come with a turf. And cardiogenic dizziness is less likely to be seen in healthy athletes, young athletic populations, but it's something that's going to get more and more prevalent as clients age, as our patients age, the more comorbidities you see. So I just say it's a healthy habit to get into. But now getting outside of that, we're going to look a little bit at the main clinical trajectories that you might see your clients or patients facing after a concussion. When I ask what a clinical trajectory is, it's kind of an interesting term that before going to UIW, before teaching there, I had actually never heard myself. So a clinical trajectory essentially is just the path that your patient or client's going to take from going to initial health state to another health state, usually being healthy and then, having post-concussion or, other times like having had a stroke, having had an acute neuritis of some kind. So the 6 main clinical trajectories that your athletes are more likely to experience are going to appear. Anxiety, mood-based disturbances, vestibular, which we'll hit on a little bit, oculomotor disturbances, which we'll also touch on briefly toward the end, cognitive, post-traumatic, and cervicogenic, cervical clinical trajectories. All of these, as you look at the clinical clusters and your symptom clusters that your patients or clients are experiencing, are going to help not only determine the path you take going forward in treatment, but also the potential route for referrals later on down the road, which we'll hit on at the very end. Now, when you're looking at those symptomatic clusters, generally you're going to see them after about 7 days, that first week post-concussion. But it's a healthy habit to get into after that first week. Follow your patients or your clients for an additional week to kind of see if their clinical trajectory has changed, if it's modified, or if they're developing, to skip ahead and answer that last question, if they're developing another clinical trajectory. Because it's actually very common for athletes or patients of all ages, all occupations, to experience more than one and to go down more than one route. So when we're looking at risk factors for protracted recovery, I got to ask, what does protracted mean to you? And I'm sure, having worked with your clients in the past, you have an idea, have an understanding of what it means for your patient or your client to be taking a little bit longer than expected to get through their concussion symptoms. And so really what it comes down to is it's actually looking at whether or not their concussion, it can actually be defined, I should say, as whether or not their concussion took place during a sports-related context. So for sports-related concussions, generally studies show that we're looking at greater than or equal to about 10 days post-concussion. That's protracted, prolonged. For non-sports related concussions, generally you get a much longer time frame, looking at about 3 months or greater. So on my end, in the acute care side, I'm looking more so at the 3-month time frame. You're seeing patients, not necessarily in sports-related concussions, but who have sustained hits to the head through mechanical falls, through accidents of some kind that lead them to come to the hospital. And unfortunately, sometimes we do see patients who stay at the hospital in the acute setting for greater than 3 months. Now, some risk factors for that protracted recovery, really one of the big things you got to take into consideration is what's going on with your patient, your client, your athlete beforehand. So what I mean by that is the comorbid situation. Is your client an anxious client? Is your athlete struggling with depression, mood disorders, disordered eating, for instance? Do they have compulsive disorders of some kind, OCD? All of these things, anxiety, depression, personality disorders, have been shown to be more correlated to a greater incidence of protracted recovery and longer when it comes to time frame. Also, the big thing, I know I was listening into the previous talk, great talk, about that locus of control, how your patient or how your client looks at their condition. If your client has a positive outlook, if they have an optimistic outlook about their condition, that actually is helpful, and not just in post-concussion settings, but in all aspects of patient-client management, whether it's sports, healthcare, hospital setting. And conversely, unfortunately, the opposite is also true. If they have a negative outlook, if they have that more external locus of control, they're more likely to take a longer course to recovery. If your client or your athlete is saying, "Oh, this is out of my control. There's nothing I can really do about it," that's partly your job, and that can also go into the referrals later on to tell them, "No, you have autonomy. You have a sense of agency here. There is something that you can do to put a positive spin on their condition post-concussion." And I can tell you, working in the ICU setting, that's where I do most of my work, that's such a major aspect of recovery. We see a lot of patients who are understandably depressed, who are understandably down, concerned. They don't know what their future looks like after their neurologic injury. And so as the physical therapist, I have to come in there and we have to tell them, "Hey, this is a new normal, temporarily, but there are lots of things that we can do to get you back to where you need to be." Putting a positive spin, putting encouragement in there is going to really help their recovery down the road. Lastly, one thing you want to look for after your patient experiences a concussion or a hit is that initial sign of dizziness. Again, I know a nebulous term, but if a patient or client reports to you that they're feeling dizzy, that actually, according to several studies, which I'll link later on, has the strongest correlation with protracted recovery. So let's go a little more, got a couple more for you. So after a concussion, you want to look for a couple of different things. You want to look for fogginess, mental fog, memory, anxiety, and also noise sensitivity, phonophobia. All of these things are associated with longer, protracted recovery And these are things you want to document, through the course of their clinical progress, from the initial post-hit, 7 days out, however many weeks out, as long as you're working with the patient. I also want to ask, because we see a lot of awesome, men's and women's sports, I wanted to pose the question, what role does gender have to play in their concussion recovery? Some studies have shown, more recent studies have shown that females actually, after sustaining a concussion, tend to have, on average, poorer or at least slower recovery. They tend to have greater symptoms, greater degree of symptoms and impairment, and also a greater degree of neurocognitive deficit. So that's where looking at memory impairment, looking at fogginess, mental clarity, all of that comes into the picture. Oh, lost the Y there. So now we talked at the beginning of the session about what isn't vestibular in nature. Like, how are we going to separate true vestibular dysfunction from vestibular dysfunction? And before we get into vestibular symptomology, we want to look a little bit about how common is this for patients to experience post-concussion. And I will tell you, at least 50% of patients or athletes post-concussion are going to experience dizziness of some kind. It doesn't necessarily mean it's going to be their first symptom, but as they go down those clinical trajectories, if they happen to go into a vestibular trajectory, you might see more of a prevalence of those symptoms. And again, as I mentioned earlier, post-traumatic migraine, another one of those trajectories, is also associated with slower outcomes, slower recovery. So that's where you might want to look into other referral options down the road. So now, when it comes to true vestibular dysfunction, these are symptoms that I myself in the acute care setting look at a lot. When a physician gives us a referral for a vestibular evaluation, I want to look at unstable vision, oscillopsia. Oscillopsia, your patient or your client might refer to you that their world feels like it's bouncing. This is more common if bilateral dysfunction, but that's essentially what oscillopsia is your patient has lost their motion stability. Imagine, the old cameras from the 90s when you're walking around, the world kind of shakes as the person's walking. That's essentially what oscillopsia looks like for your patient. So, yeah, that's something you definitely would warrant a referral out to either neurooptometrist, physician, neurologist, if your patient's reporting that. Difficulty focusing, not necessarily related to mental fog, although it could be. More so in this context, we're looking at oculomotor dysfunction, reading, those kind of things, being able to switch from targets, close distance, far distance. Those might all be impaired with patients who have vestibular dysfunction. Motion sensitivity goes a little bit back to that loss of gait stability, but motion sensitivity is actually very common for patients who have both unilateral and bilateral dysfunction, and most commonly seen with turning the head, having difficulty in crowded environments. They don't want to go to the store, they don't want to go to the school, they might have a lot of issues traversing campus if it's a busy day, a lot of students out and about, because their mind is trying to process not just where they're at in space, but everything moving around them too, which, as I'm sure you can understand, is very debilitating. And lastly, imbalance. Imbalance is such a major aspect when it comes to vestibular dysfunction. When we're looking at the absence of dizziness in visual input, what I mean by that is, what I like to tell my patients and what I like to tell my students is that, we as humans, we function on 3 major balance systems. Our eyes being one, our inner ears being the other, and then our proprioceptive, joint receptor input that we get from our legs, our feet. All 3 of those coalesce to kind of help you, get an idea of where you are in space, how fast you're moving in space, how your position's changing. If your patient has true vestibular dysfunction, true inner ear dysfunction, then you're going to actually be looking more at how their sensory weighting is affected. Be it are they more visually reliant? Are they more proprioceptively reliant? Are they more vestibularly reliant? And there are a couple tests that you can do to actually really get to the bottom of how their senses are being weighted to keep their balance. So here's a question for everybody. How many of you are familiar with the VOMS screen? Okay, and would you say, or how many would you say implement it on a regular basis with your patient post-concussion? Okay, very nice. So, for those of you who are not as familiar with the VOM screen, the VOM screen is actually developed, in part for use with athletes, post-concussion, that sports medicine context. And it consists of 5 main items. Smooth pursuits, where you as the clinician or the practitioner are looking at your client's extraocular movement, follow the finger side to side, both visual fields, vertical, inferior tracking, horizontal and vertical saccades, which are pictured up above, near point convergence, looking at when the object becomes double as the visual target comes close to the bridge of the nose, vertical and horizontal VOR. Only the horizontal component is pictured up here on the slide, and the visual motion sensitivity screen, which is the farthest down bottom here. So I want to kind of just introduce the VOMs, for those who aren't as familiar with it, but we'll get a little bit further into it here when we're looking at the VOMs versus a vestibular evaluation. Now the VOMs, as the name implies, the VOMs is a screening tool. When I say here that it's performed actively, what we mean is that we're having the patient or the client actively move their head or move their trunk, with a set cadence associated with that specific test. So 180 beats per minute for the VOR screen, it's just the head being moved. Whereas for the visual motion sensitivity screen, your patient is moving their entire trunk, trying to keep their eyes focused on the target in front of them. And we're going to get a little bit more into abnormal findings in just a sec. But the vestibular evaluation, what that is it's a passive assessment. Vestibular evaluation is more commonly going to be performed by your general practitioners, your otolaryngologists, the ENTs, the neurooptometrists potentially, and physical and occupational therapists. We as practitioners, when we're doing a vestibular assessment, we're actually taking the patient's head in our hands and we're moving the patient's head. We're telling them to relax. We're hoping that they're going to relax, which I promise you they don't always do. But we're moving their head to elicit some sort of reflexive response, whether we're looking at the VOR, whether we're looking at their cerebellum's ability to inhibit, visual motion sensitivity, which I'm going to compare in just a sec. The big thing between these two is that the VOMs is looking more at symptom provocation. And there's the fogginess, dizziness, headache, nausea. Whereas a vestibular assessment is actually looking more at oculomotor quality. When doing the VOMs and when doing a vestibular assessment, you may well get the same objective findings when it comes to oculomotor malalignments, oculomotor dysfunction, but the way they're graded on the VOMs versus a vestibular assessment is different. On the VOMs form, you would probably write that under the notes. You're not so much looking at the patient exhibits, corrective saccade to the left side with head turned to the left. You're looking, just kind of saying, okay, they had a corrective saccade, make a note of it. Now, speaking of abnormalities, speaking of red flag findings, these are some things that might warrant outside referral to, again, the neurologist, neurooptometrist, vestibular specialist, physical therapist, etc. When we're looking at central signs, what that refers to is dysfunction in either the brain or the spinal cord. You might see some cranial nerve involvement, but that's where it's kind of, a gray area. You're looking at what type of cranial nerve dysfunction will kind of determine how severe the dysfunction is or how severe the need is for a referral. But saccadic intrusions, you're more likely to see those elicited during the smooth pursuits or during the visual motion sensitivity. Saccadic intrusions being the eye's inability to follow a smooth trajectory. If you're having the patient follow your finger, and instead of following nice and smooth like this, their eye jumps from point to point, that might be an indicator that there is potentially some cerebellar dysfunction, as your cerebellum is the part of your brain that controls your eye's ability to track during smooth pursuit. Visual motion sensitivity. Similarly, if you have your client or your athlete follow their finger as they move from side to side, I'm trying to get the balance here, they move from side to side, you might see that your patient or your client has difficulty following their fingers smoothly all the way through, and their eyes might lag behind momentarily, having a saccadic jump between points. So that's the difference, really, the big thing between the VOMS, visual motion sensitivity, and the cerebellar screen of vestibular assessment. Direction changing nystagmus is also a big one when it comes to red flag. If you're having your patient or your client follow your eyes from side to side, if you see a right beating nystagmus as they're following to the right side, and then have them follow to the left side, and that nystagmus starts to beat left, that could be an indicator that they may be experiencing something, either a stroke, and that's very common post-CVA, or you may have some sort of cerebral damage that needs to be addressed urgently. Dysmetria, you're going to see that when it comes to saccadic testing, looking at their ability to jump between 2 points. And you're looking for either hypo or hypermetria. Are they overshooting the target, or are they undershooting the target? Those things, again, are more akin or more related to cerebellar dysfunction. And so, actually, yeah, just getting horizontal and vertical. That's what I was looking at there. Got a little thrown off. And then lastly, dysconjugate gaze. So dysconjugate gaze is not in and of itself a red flag, an urgent indicator for referral out, but I've attached this picture up here because the hyper or hypotropia is what's more associated with potential brain injury. The eyes deviating upward, the eyes deviating downward. It might be exposed if you do the cover or the cross-cover test, or the patient or client may have it in a resting state. Either way, that's something that you do want to refer out pretty urgently if the patient has not been seen by a neurologist or been seen by a other practitioner. Sometimes our clients, we ourselves, we might have a mild strabismus, a malalignment medial or lateral of the eyes. It's fairly common, it's not necessarily pathologic in nature, but if it's new, if you find that's something that's new after the concussion, or when you're performing a near-point convergence test and your patient might say that they never see double, an underlying strabismus might be the cause of their inability to converge or diverge when you're looking at the target. So let me see, I think, yep, that's it. Yeah, so, when it comes to referral, I've hit a lot of times neurology. Neurology are some of our best friends when it comes to vestibular. Otolaryngologists, the ENTs, they also, I love working with them because they can really get to the bottom a lot of times, what is the underlying cause of these dysfunctions, whether it's brain related, whether it's peripheral, vestibular related. I refer to my patients, even in the acute care setting. If we don't have access to an ENT, I will often refer them to them, just in case, if it's something that we as the PT cannot get addressed in the acute care setting. If you're an outpatient, if your patient or your client is being followed by neurology, by some sort of the neuro team, they may benefit from referral to a vestibular physical therapist. And so, I spoke to Sean earlier regarding this. I want to be upfront and say, when it comes to the physical therapy realm, I myself don't get to work a lot with, sports medicine colleagues, because most of the work that I do, it's in ICU, very acute setting. So I'm not fortunate enough to be able to really have a big network of sports medicine colleagues to refer my patients to after they leave the hospital. However, I'm very big on building referral networks. I'm very big on having as much access to, quality care for our patients, for our clients as we can. So I do want to put out that I myself, in my clinicals, was trained by a vestibular specialist. She's also a neurologic clinical specialist. She, I believe, works in a private practice, but she works out of the University Hospital Pavilion in the medical center. So if you ever have, patients who are going through these prolonged, protracted recoveries, and you might be seeing plateaus, or you have some concerns when it comes to implementing, further vestibular rehab, then I would definitely say she's a very quality, very quality networking companion to reach out to. Her name's Dr. Shara Rodriguez. But this is really, what I have here today. I wanted to try and kind of bridge the gap a little bit, give you something to look out for when you're working with your patients or your clients, because multidisciplinary care is so important, especially in the neurologic realm, especially when it comes to return to play. So if you do have any questions, I think we actually lost a slide in the formatting, so I will be giving, I will be giving my contact information. I'll be absolutely forwarding another reformatted version of the slide to Sean, so that if you have any questions regarding outreach or any questions regarding the data that we presented here, I'd be more than happy to answer any questions that you have. Thank you.
Absolutely. There you go. Appreciate you very much. Thank you so much.
Thank you, Chris. Obviously, one of the things that we want to definitely see here is that, and that we're trying is show a little bit of